Yeah, now I'm audible. So we are going to talk about management of pterygium. And first we are going to discuss the conceptual evolution of pterygium in both primary and recurrent pterygium. Then we'll go on to talk about the evolution of the different securing techniques that we have. Then we'll discuss the perfect technique. Then the newer techniques of mini sled and per with mini sled. So that's how this instruction course has been planned. And I think Dr. Rishi will start with his talk and then subsequently we'll progress.
Thank you, ma'am. Good evening to you all. I'll be talking about the historical perspective of pterygium. Pterygium is derived from a Greek word tergios, which means wing, a surface eye of thalmoheliosis, a Cinderella's ocular disease, truly defined as a triangular wing-shaped degenerative fibrovascular hyperplastic proliferative tissue. The initial pterygium belt was described by Cameron, 37 degrees north and south of the equator, 0.3 to 29% worldwide, and in India, 9.5 to 13% more in rural areas. Pathogenesis, multiple etiopathogenesis in it. Historical view states that it's a degenerative condition. Multiple theories based upon cell proliferation, hyperplasia, migration, UV-induced oxidative stress, limbal and bone marrow stem cells contribution, and possible potential involvement of neurogenic inflammation from the UV-injured corneal nerves. This is a diagrammatic representation of the various mechanisms involved in the pathogenesis of pterygium. We move on to the classification of pterygium. There is a Tanatal grading, which is based upon the visualization of the episcleral vessels as an atrophic T1, where the episcleral vessels are clearly visible. An intermediate one, a T2, where the vessels are partially obscured. Then comes the fleshy, that is T3, where the episcleral vessels are totally obscured. This is a clinical grading. We'll be going to two more classifications, that is Verma et al. And Sejal Maheshwari. It's basically based upon the distance from the limbus. Grade 1, midway between the limbus and the pupillary border. Grade 2 extends on up to the pupillary border. Grade 3, it crosses the pupil. Now comes the indications for surgical intervention. History of progression, astigmatism causing poor vision, the proximity to the visual axis, poor cosmesis, recurrent inflammation and concern about a malignant change. The history of pterygium surgery dates back as behind as 1000 BC, where Sushrut, where the pterygium is sprinkled with salt, he looks laterally, it's hooked with a, clasped with a hook, and it's detached from the ocular surface with a round end knife and a sharp cutting edge. And an unguent is applied in order to avoid the recurrence. There are various procedures described historically as a Celsus procedure, a Paul's operation, a Corellia of paste of honey, Hippocrates' colliery of zinc, copper, iron, bile, Bartish and Senat, and divine sown. The various surgical techniques, 1903 Mec-Reynolds transplantation technique, Panzardi's use of amniotic membrane grafts in 1947, Rosenthal, the Bayer sclera technique, Kuntumo and Muri, mitomycin C in 1963, and a conjunctival autograft in Keon in 1985. Then came the Stalker, the conjunctival Z-plasty for primary closure, DT Tan conjunctival transplantation, and Hurst, the perfect. Next comes the major bugbear when we perform the pterygium surgery. 90% recurrences occur between the first and the third month. The clinical predictors, incomplete control of post-op inflammation, excessive suturing, incomplete removal, post-operative graft retraction, a higher morphological grade of the pterygium, more fleshy, with heavy vascularization. And especially in young people, a double pterygia and non-translucency, that's a significant risk factor. And Prabhatiswa has given a common method to grade the recurrence. Grade 1 when the operated site appears normal, a grade 2 when there are fine episcleral vessels in the excised area extending to the limbus but without any fibrous tissue. Next comes the grade 3 where the fibrovascular tissues are reaching the limbus. And once the true corneal recurrence takes place with the fibrovascular tissue invading the cornea. Medical management based upon reducing the inflammatory symptoms and the discomfort with benign agents, toxic agents, lubrication, the topical NSAIDs, and decongestants. Surgical approach, there are multiple approaches, right from Bayer sclera excision till the Hurst technique of perfect. We have transplantation redirection and other ocular surface transplantation techniques. The adjunctive therapies involve the corticosteroids, thiotepas, cyclosporin A, mitomycin C, 5-fluorouracil. The anti-VEGFs, the interferons, and use of a fibrin glue and autologous serum. The Bayer sclera technique has about a recurrence of 24 to 89% with other adjuvant options. Next comes the conjunctival or the conjunctival limbal autografting, about 1 to 40%. The amniotic membrane transplantation, general recurrence about 2.6 to 42. Now the treatment for recurrent pterygia. No option is impervious to failure. So a repeat conjunctival autografting, use of an amniotic membrane, application of MMC, a CLAG, injection of 5-fluorouracil, and even administration of subconjunctival anti-VEGF agents have been tried. Management of complicated cases, of course, involve a holistic approach, which involves a lamellar keratoplasty, a split graft for a double pterygia, and a combined approach we use as CAG, we use amniotic membrane to prevent the fibrosis, the movement restriction, and closure of defect. This is then and now 1906 Mac-Reynolds pterygium transplantation and the perfect technique. Main complications of pterygium surgery: intra-op, excessive bleeding, MR muscle injury, possible chance of globe perforation, post-op, recurrence most common, edema, Dellin formation, persistent epithelial defects, graft necrosis, graft retraction. Thank you so much.
Thank you, Dr. Rishi. May I invite Dr. Ekida to present on the technique of securing the grafts after pterygium excision.
ये वाला, हाँ. All right. So, very good evening. I'll be talking about pterygium excision with conjunctival autograft and how the securing techniques have evolved. So, let's first talk about what is the goal of the surgery. What are we really looking for when we are talking about pterygium surgery? First and foremost, a good cosmetic outcome, because most of these patients come to us because of cosmesis. Second is minimizing the chances of recurrence, because the main complication of pterygium surgery is recurrence, and recurrent pterygium behaves very differently from a primary pterygium. So we want to avoid recurrence. Now, the technique of conjunctival autograft, which was described by Kenyon et al. In 1985, gives us a good cosmetic result and has a low recurrence rate, although the recurrence rate is very variable between different studies. So therefore, this remains the standard of care. When we talk about pre-operatively, what are the things that we should look at? The anesthesia could be peribulbar or subtenons. I personally prefer peribulbar anesthesia when we are talking about pterygium surgery. We could either be superior or temporal, whatever works better in your hands. And instilling topical brimonidine for a couple of minutes, maybe 10 minutes before the procedure, helps in reducing the amount of intraoperative bleeding. So these are the preoperative concerns that we should keep in mind. Next, let's discuss, to understand the surgery better, let's discuss what are the different parts of a pterygium. We have the head of the pterygium, which overlies the cornea. Then we have this body of the pterygium, which is basically the part which overlies the conjunctiva, and the junction between these two is called the neck of the pterygium. All this whitish degenerated tissue that we see here is actually the elastotic degeneration, and sometimes you will even see pigmentation around the neck, and this is the part that needs to be excised. So we nick at the neck of the pterygium. So let's break it down into different steps of the surgery. We have excision of the head of the pterygium, then we have dissection of the subconjunctival tissue, which is very important to prevent the recurrence. Then further we harvest the conjunctival autograft and secure the graft in place. So most of my talk I'm going to start with the initial steps, but I'm going to concentrate mainly on how the technique of securing the graft has evolved. So first, let's start with the first step of the surgery, which is excision of the head. So in the first video here, what I'm doing is I'm stripping the head of the pterygium from the corneal surface using two sharp forceps and then subsequently excising the head of the pterygium. In the second video here, I first undermined the neck of the pterygium and then excised it so as I have to free the head of the pterygium. And now this free head of the pterygium is stripped from the surface of the cornea. One sharp forceps for countertraction is used and the other to strip away. In both of these techniques, it is important that we remove all of the residual tissue that is present on the corneal surface, and a number 15 blade forms an ideal instrument for this step as it is sharp enough but not as sharp as a crescent. So sometimes, rarely, we might come across cases like these where we have a large adherent pterygia with underlying corneal scarring, and if we see a patient like this, we must ask for certain questions. A history of prior trauma or chemical injury, or if the patient has undergone prior pterygium surgery or history of microbial keratitis. So these pterygiums can behave very, very differently, and here in these cases we might resort to a crescent knife where we have a large adherent pterygia. We have to be a little careful while using crescent as it's sharper, so we have to avoid a multiplanar dissection and avoid going really deep. That can cause a significant amount of irregular astigmatism. Now, next step is harvesting the conjunctival autograft. Here our aim is mainly to have a thin graft with least amount of subconjunctival tissue, so it sits in better, we can stretch it nicely. The size when we are harvesting, we can keep it a little larger, maybe 10% larger than the defect that we have created, because we really don't want to leave any bare sclera behind, and if it's larger than what we require, we can always trim it down. So here I'm using a combination of blunt and sharp dissection techniques and then going ahead and dissecting this tissue and harvesting the graft. We can use subconjunctival lignocaine or BSS if required, if that helps in delineation of the plane. And we can also mark for the orientation, especially when we start out with the first few cases. So once we have harvested this graft and we have a free graft, we are going to flip it because we want the conjunctival side up, the conjunctival epithelial side up. So we flip it in place, and then we see the orientation, assess the size, and then we can place it where we need the graft to be. So limbus towards limbus, make sure that the orientation is right, and then slide it into place. So now we'll talk about the different different securing techniques. The first is anchoring the graft with sutures. So let's just see how we do this. Here I'm using subconjunctival lignocaine to balloon up and find the plane between the conjunctiva and the Tennant's capsule. And once we have a graft, I'm using interrupted atovicral sutures with episcleral bites. Taking episcleral bites really helps because it anchors the graft down and helps in preventing ballooning of the graft or hemorrhage underneath the graft. So 2 sutures on either side. We can also use tenno nylon for the perilimbal sutures if required, especially when we have a large pterygia, then and we need to put a suture in the middle as well, then we can use tenno nylon. Otherwise, atovicral works really, really well. So 2 sutures typically on the limbal side and a couple of 3-4 sutures on the conjunctival side. So this is how the anchoring began, initially with sutures. Then let's look at the technique that we use now, which is using the fibrin glue. So I'm going to go over the entire surgery, put everything together because we have seen the different steps of surgery. So let's look at the entire case. This is the same patient whose the excision of the head I had shown in the beginning of the surgery. So here, just to reiterate that we need to clear off this remnant tissue from the cornea. It is extremely important to avoid irregularity and also to give a good cosmetic outcome. And then the next step, very important, is dissection of the subconjunctival tissue. So here you can have your assistant help you and then hold on to the Tennant's capsule. Use a combination of sharp and blunt dissection. I'm going in with my scissors closed and opening my scissors as I go in, so as to really dissect the tissue and then free it from the overlying conjunctiva and the sclera underneath, and then excise this tissue in all the directions. So we have to be very careful about the medial rectus, especially when we are starting out. If you're unsure, you can hook the medial rectus. Then the next step is harvesting of the conjunctival autograft. Here, it helps if you have an assistant who can just take a bud and then rotate the eye downwards and nasally so that you have access to the superotemporal quadrant, which is typically from where we harvest the graft. And once we have harvested the graft, we can see that it's slightly larger than what I really need. So we can always trim it down. A tip here is to use fibrin glue, thrombin and fibrinogen, both components, in two different needles mounted on, two different syringes mounted on 26 gauge needles. This avoids clumping of the glue, typically with the Diplojet injector that happens, the one that the glue comes in with. Then we put the graft in position, iron it out, and a very important step for cosmetic outcome is to trim this excess overhanging tissue. If we have overhanging tissue on the corneal surface, that might not look very good post-operatively, so trim that excess tissue down. So let's look at advantages of using fibrin glue over sutures. So initially the sutures are what were used, but how does fibrin glue really help? It definitely shortens the surgical time. This is a Cochrane review which was published, and here they found on an average a surgeon took 17 minutes lesser when they used fibrin glue as compared to sutures. Patients are more comfortable, and there is some low level of evidence to suggest that there might be lesser chances of recurrence. Recurrence is basically dependent on inflammation, and sutures tend to cause more inflammation, especially absorbable sutures, rather than fibrin glue, and that's the reason why there could be higher chances of recurrence with sutures. And of course, there are no suture-related complications. Now, surgical time specifically becomes very, very important when we are talking about a combined surgery, pterygium plus cataract surgery, or we are looking at patients with double-headed pterygia. Now, in a double-headed pterygia, we use a split technique where we split the graft into two and place it on either side, the nasal and the temporal. Here, a fibrin glue can be used, and most of the cases, it's enough for us to just split the graft and use it in both the places. But sometimes when we have a large double-headed pterygia, we might need to require AMG. And then we might need to use sutures, because if we have an amniotic membrane graft, and on top of that, we need to put a sliver of the conjunctival autograft near the limbus so as to prevent the recurrence, because we know that the recurrence rates are higher when only an amniotic membrane graft is used and not a conjunctival autograft. Now, are there any disadvantages of using fibrin glue over sutures? The major one is, of course, all of us know that it is much more expensive. There is again a low level of evidence to suggest that there might be higher chance of graft dehiscence, but we need to understand that graft dehiscence is dependent on various factors: how we prepare the graft, the manipulation of the graft, the surgical expertise, and how we have counseled our patients post-operatively as well. So at this point, I'll just share a few of the tips to avoid this complication of graft dehiscence, and a few things that we can do when we are using fibrin glue. First is prepare a thin autograft so that it stretches out better, it sits in better, there are lesser chances of it getting dislocated. Dry the scleral bed before application of the fibrin glue so that you do not have hemorrhage or excess fluid. Use both fibrinogen and thrombin separately in two different syringes so that you have a thin layer and you get time to really anchor the graft. Slide the graft in position and iron it out, and then it sits in really, really well and less likely to get dislodged from its position. Another important tip here is to trim the excess glue instead of pulling it, because if we pull the glue, we might be pulling the autograft along with the glue. So always use scissors, make sure that the speculum is free of the glue before we remove the speculum from the eye. And last but not the least, to educating our patients. Now, there's another technique of using autologous blood, which is patient's own blood, induce fresh bleeding so that the fibrin in the blood itself adheres the graft. But I do not prefer this technique because it has been shown in different studies that it does have higher complication rate, even higher complication rate in terms of graft retraction and graft loss. But there are a lot of surgeons who've been using it for many years and find it pretty useful. Now, post-operatively, these patients are put on steroid eye drops, typically for 6 to 8 weeks, which are gradually tapered. Antibiotic eye drops for about a week, and tear substitute eye drops again continued for 6 to 8 weeks. So to conclude, conjunctival autograft is the current standard of care for most of our cases, and it works well. We need to have a thin, meticulous preparation of the graft. Anchoring the graft with glue over sutures, which is an evolution in the securing techniques, gives us a good cosmetic outcome, reduces our surgical time, and is more comfortable for our patients. Trimming of the excess glue is essential at the end of the surgery. Thank you so much.
Thank you, Dr. Ikeda. It was excellent presentation.
I'll call upon Dr. Swapnil Bhalekar. This side. ये वाला चल रहा है. I'll be calling upon stage Dr. Swapnil Bhalekar for the perfect technique. Is it perfect for the primary and recurrent pterygium?
मैन्युअली चला किसमें फोल्डर कहाँ पे है? अच्छा ये पे है ना, ओपन ये वाला ना. हाँ ठीक है, ठीक है, ठीक है. Good evening. So before going into the perfect technique, I would again like to go into the basic pathology of pterygium, and let's discuss about how recurrence occurs, because it is very important to understand the perfect technique, which is probably the only technique since last 10 to 15 years which has shown almost near 0% recurrence rate. There is no other technique published which promises that much low recurrence rate. So let's try to understand. If we look at the pterygium, we know that it is a kind of a focal limbal stem cell deficiency secondary to sunlight exposure or any other damage, and that's how this conjunctivalization of the corneal epithelium occur. If we look at the histopathology of pterygium, we can see that it is nothing but the elastotic degeneration just beneath the conjunctival epithelium. And if we look at the UV exposure to the skin and what we call it as actinic keratosis, there also the pathology is elastosis. Why this background was important? Because elastosis is histologically a different terminology compared to the what we see in recurrence. Now, recurrence is the most challenging scenario in pterygium surgery, because whenever we operate young patient or anybody, we are feared about recurrence. So it's very important to discuss what recurrence is. So this is how recurrent pterygium looks like. Appearance-wise also it is very different. There are different methods of pterygium removal he has already discussed. But why there are so many methods? Because there is lack of consensus. Usually that indicates that no one method is superior, but we have to find out theoretically which method should be better. So the most commonly used method is conjunctival autograft, but if you look at the PubMed published articles, the recurrence rates vary from almost 2% to 39%. Why? Everyone is putting the graft, everyone is removing the pterygium. Why such a variedly reported recurrence rate? So let's see. So why recurrence occurs? So recurrence is nothing but whenever, initially we used to use a bare sclera. So there is a kind of a fibrovascular tissue formation or granulation tissue formation, and which forms the recurrence eventually. So if we look at the recurrence as a histopathologically, the primary and recurrent pterygia are completely two distinct entities. So recurrence is actually not a good term. It's a wrong term to use. Recurrence is not recurrence. It is a secondary healing response, which is nothing but a fibrovascular tissue. So if you just take the histopathology of the primary and recurrent pterygium is nothing but elastotic degeneration, which occurs secondary to the exposure to the sunlight. And the recurrence is nothing but what we call recurrence. It is not actual recurrence. It is a fibrovascular proliferation, which occurs secondary to the aggressive healing response. So let's see. So that's why the recurrent pterygium is not true recurrence, and in actual it is a fibrovascular proliferation. Then why it is formed? So let's go back to our Robbins pathology. So this, I think everyone would remember this terminology: primary and healing with primary intention, healing with secondary intention. We all have learned this, in our Levenbilly and Robbins. So what happens in healing with primary intention is there is less granulation tissue is formed. That's why the cosmetic appearance is better. And in healing with secondary intention, what happens is granulation tissue is more, so scar is more exuberant, scar or keloid formation occurs in secondary healing with secondary intention. Now let's go to the donor site. How donor site heals? Because we keep the underlying tenons intact. What happens is from the limbus and the conjunctival fornix, again the epithelium starts growing over the donor site and it gets epithelized. So this is healing with primary intention. However, if we cut the tenons at the graft site, donor site, if we all know that it forms the pyogenic granuloma, that is nothing but the secondary intention granulation formation. So, so what actually recurrence is? Recurrence is nothing but there is a healthy tenons beneath the pterygium as well as surrounding the pterygium. So whenever we try to excise the pterygium, we kind of bridge the ocular surface. whenever there is a breach in the ocular surface, the healthy tenons surrounding the pterygium is going to cover up for the defect we have created, and under the graft, around the graft, it starts forming the fibrovascular tissue and granulation tissue, and that's how the recurrence occurs. Eventually, fibrovascular tissue is formed eventually. So what we can do about it? So if we are seeing that healthy tenons or the tenons surrounding the pterygium tissue is the culprit behind healing with secondary intention and formation of fibrovascular tissue, then we have to go aggressively and remove the complete tenons beneath the pterygium from suprarectus up to infrarectus up to medial rectus. Everywhere we have to remove the tenons. Then probably there is nothing left to respond, because tenons is the one which is going to respond, for going to form the granulation tissue, going to induce the healing effect, and going to form the recurrence. So what perfect technique is, it is about the pterygium extended removal and extended conjunctival autograft. So Lawrence Hurst from Australia, who has proposed this technique many years back, he has done thousands and thousands of cases and published it, and it is probably the only technique which promises 0% recurrence rate. So it is at least my go-to technique, but only thing is we are going to go about it, but I have just modified it a little bit. We'll go into it. So what extensive tenons removal will do, it will limit the secondary healing response from the surrounding tenons and subsequent fibrovascular tissue formation, which we call it as recurrence. It is not actually recurrence. Elastosis doesn't form again. It is a fibrovascular tissue. It is prevented. So this is the first study which he published, about 250 patients, and almost every patient had a 1-year follow-up, and again this study had a nearly 0% recurrence rate. You can go through the study. It is beautifully designed study as well. This is the technique. I'll just play it from the outside. I'm not able to play it from here. So let's see how he does it. So before we'll go into the schematics. So what he does is, you can see once he has removed the neck, extensively he is going and trying to remove the tenons all around. Then he also hooked the medial rectus muscle, around the muscle, all around he has removed the tenons. And then extended graft means he has to take a very large graft which goes almost up to the fornix, around 10 millimeter behind the limbus. And then he takes a large graft. The only thing here is he hooks the medial rectus muscle, also removes the medial rectus sheath which is covered by tenons, and then he sutures the graft all around, which gives a very nice cosmetic appearance, probably the only technique having such a good cosmetic appearance. But recovery takes really longer because it's an extensive resection, as well as he is also using the sutures. Oh, just 1 second. And I'll just show you his video. So this is its technique. So there is an extensive resection all around. Once he removes the head, after that he just go behind the tenons, because the tenons is going to induce the secondary healing response. So more tenons you leave, it is going to create problem. And you can see he has already hooked the muscle and trying to remove the muscle sheath as well, which is made of tenons again. And he goes out almost up to orbital septum. So this is how extensive recurrence is, and then the whole graft, which is going to be super large, is going to suture all around. So this is the background where how perfect technique is done originally. Obviously, we'll see how practical it is. So this is how he takes a very, very large graft and then suture it all around up to almost medial side. So this was about perfect technique. So let's see, what are the results. So this is a study he published later around in 2012, about 1000 cases which were performed with perfect technique, and there was only one recurrence, and it is categorically mentioned in the article that it was performed by his fellow and the tenons was not probably adequately removed, but otherwise in 1000 cases 999 there was no recurrence. So probably these are only by Lawrence Hurst there are perfect technique which is published since last 15 years. He has been publishing many articles, and they have shown really promising 0% recurrence rate. Also he has done a study on double-headed pterygia treated with perfect for pterygium, again 0% recurrent rate. He has also studied the cosmetic outcomes, and the surgeons were asked to identify the eye which was operated, and it was very difficult to identify because it was going almost up to medial canthus. So cosmetically also it is best. Only problem is it needs an extensive resection, surgical time, pain is a lot because there will be a lot of sutures, and the post-operative recovery is also very slow because you are excising so much of a tenons. How I do it, I really don't actually practice the same technique, but I use the same principles. This is also not peeling. I'll just play it from the outside. So this is how I do it. So once we inject this lignocaine with adrenaline, I inject usually beneath the pterygium. So I try to similar way I try to undermine like Ikeda showed, separate the subconjunctival tissue from the overlying conjunctiva. So here, one thing to be noticed is sometimes conjunctiva is very much adherent to the underlying tissue, and at that point, sometimes we have to compromise the conjunctiva as well, because if we keep that bulk of the underlying pathologic tissue, it is again going to act as a it can induce the secondary healing response. So here, this is very important. You have to reach almost up to orbital septum. So you can see I am trying to zoom, and that whitish thing, beyond that there will be orbital fat, that whitish thing. So that is orbital septum. So the healthy tenons is almost up to that point, healthy as well as diseased tenons. So you have to go almost up to that point. So I am trying to undermine again here. So everywhere you have to go from superior to inferior to medial rectus everywhere, and you have to remove all that tenons. So once the dissection is done, then I remove the head, because once you remove the head, then giving traction becomes very difficult. Here I am able to give the traction properly because I have not excised the head. So I do it last. And this is how, once I remove the head, now you will see that it's a huge bulk of the pterygium tissue. I usually avels it and then use usually my 15 number blade or maybe a diamond burr for polishing the pterygium residual area. And this is how from medial rectus also you have to separate it properly. I don't hook the muscle because can you see the orbital septum there? That shiny part is the orbital fat. So up to that point, the point I am marking, up to that point you have to excise. Yes, and this is also large chunk of tenons. So it is very important to excise all the tenons if you really have to achieve a less recurrence rate, especially in young patients where we have a lot of fear about recurrence. So here I am excising almost up to orbital septum. I have taken care to identify the muscle also. You can see the tendon beneath, but not hooked it like Lawrence Hush does. So in my case also, now the area is pretty large. It is not very small. So it is going to really need a larger graft. And again, this tissue is also very important to clean it because it can also induce sometimes you can see fine vascular things forming at the on the cornea. So it's probably that is also residual tenons that can also induce the healing response. So I usually don't inject anything before taking out the graft. My technique is slightly different. So I kind of again give a very good traction. While once I give these 2 incisions, I give a very good traction and just try to separate it from the highest point where tenon is inserted. So that's how I make sure that the underlying tenons, you can see there is no bleeding, nothing. It is completely excised and the graft is also completely transparent. So I don't inject because I feel that injecting inflates the tenons and we just get a false sense that we have not cut the tenons. But we just unnecessarily inflate the tenon and make it bulky so that some kind of tenons remains beneath it. So I never inject as such, just do like this and try to excise the tenons. So see, again I'm taking the highest point and trying to separate the tenons at every point. So you can see that donor side, because now we are taking a larger graft, we cannot afford to have a tenons excised, and this is almost a transparent graft. And then rest of the things remain same. I just use fibrin glue all the time to secure the graft. Rest of all the steps Ikeda has already explained. So this is all about how I do modified perfect technique. Only thing we have to take care is excising the tenons completely. Now let's see what he has done in to prevent the pterygium recurrence. We have already gone through it. So here he also exploited this technique into the recurrent pterygium management. And again, this is the only technique in recurrent pterygium management which has promised 0% recurrence rate again, right? So management of recurrent pterygium, again, now we know that it is not recurrence, it is not primary pterygium. We again have to go behind the fibroscalar tissue, remove as much as possible. We have to cover the bare area with stable epithelium. Why I use this word stable epithelium? Actually, AMG should not be labeled as stable epithelium because it can get dissolved. So ideally, conjunctival autograft or MMG. These two are the stable epithelium. Whenever I use MMG, make sure that it is very thin and it is spread tightly across the surface, bulbar surface. It works wonder. It looks like conjunctiva only. And you can cover bare area with all these things. You can use mitomycin C, but be judicious. Don't use it a lot. Sometimes it can cause melt. So that was all about perfect technique. Thank you so much.
So if we have any questions, we can take up 1 or 2 questions on 2 different techniques. Otherwise, we'll go ahead with the talk on PER plus with mini sled together. Have we reached zero recurrence by Dr. Amrita Joshi. Any questions on the 2 different techniques or any thoughts or comments, anything? How many of us are doing pterygium surgery? Any comments or anything you would like to share that you do differently? Maybe 1 or 2 comments we can take.
Ideally, thick component should be applied first, because if you apply the thin component first, it will flow away and then you will put the thick component on the bare sclera again. So better to apply thick component which will get retained on the surface and then apply thin component.
Similar.
Yeah.
I do the same.
Yeah. So yes, so I'll label it as categorically not recurrence, impending recurrence. So what impending recurrence is, initially when you are following up the young patients, you might find a fine leash of vessels going onto the cornea through the limbus. That is impending recurrence. When it is impending recurrence, that means it is at the stage of granulation tissue formation or early fibrosis. It works in early fibrosis. You can inject subconjunctivally, fibrosis, it works wonder. But once it is established recurrence, that fibrosis is already formed, there is no active fibrosis which is forming, then it doesn't work, because 5FE work on actively, it is a metabolic, we call it as, it works at a stage where there is a proliferation. So it will work on granulation tissue, but you have to identify, that's why these young patients should be kept under follow-up every month. The moment you find that leash of vessels going through the limbus, you have to inject every weekly. You can inject 3. That's what I do, and it just makes it disappear. So in my 10 years of practicing this technique, I have never seen any recurrence till now. Topical, I don't think it will work. It would be like placebo, at least for pterygium. Because see, the fibrosis is beneath the formed epithelium. Right, when you use it for OSSN, it is lying on the surface, so it is acting directly on the surface. The pathology is on the surface. Here pathology, it is covered by the healthy conjunctival epithelium, columnar epithelium, and beneath that there is a fibrosis. So I don't think it will reach there and then it will prevent the fibrosis. But trust me, there is no harm in injecting subconjunctivally. You can inject it. Right. Topical. Yeah. Yeah, possibly. That's good. So on the corneal part, it might work. But what I feel is, if you really want to go in young patients, if you really want to attack it properly, it's better to inject. Yeah.
But if we have a corneal recurrence, if we have reached the stage where we have a corneal recurrence, I think it's unlikely that 5FU will work. And probably we are better off taking the patient up for a surgery again and doing an extensive dissection, being much more careful, probably using either 5FU or mitomycin C intraoperatively.
I do topical most of the cases. Yes. 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 And I think if you really want to read about this, there are very beautiful articles about impending recurrent pterygium. Use the term impending recurrent pterygium, and use of 5-fluorouracil. There are good studies about it, and it works really wonder. Any other question? So we can go ahead with Dr. Amrita's talk. about per with mini slate. Please go ahead.
All right.
Thank you.
Thank you. So I'll be speaking about pterygium extended removal followed by minor ipsilateral simple limbal epithelial transplantation. It's basically the perfect technique as sir has already spoken about. But we are dealing here now with recurrent pterygium, which we did not want to occur, but it has. So we have a couple of patients which I'll be discussing today here. Now, this is the patient. She's a 61-year-old lady. She has a recurrent pterygium, operated twice. She is also a case of open-angle glaucoma. So, what do we have to do for her now? If we go ahead with the perfect technique, we need that big conjunctival autograft from that superior temporal aspect that sir was discussing about. But that superior temporal aspect, we might in future contemplate a glaucoma surgery for this patient, and we would like to preserve that area. So what can we offer this patient? Sir, we have already, sir has extensively spoken about these publications where how good the perfect technique is. But here in our patient, we would like to preserve the conjunctiva. So we slightly modified this technique, the perfect technique. So what we were doing in perfect technique was we were removing the diseased tenons and the pterygium completely in an extended fashion, and then we were putting an autograft there. But here what we are doing is we are doing the same thing. We are removing the pterygium, extended removal, but we are putting a AMG now over that bare sclera. And we are removing superior temporal aspect. We'll take around 1 clock hour of limbal tissue. And we'll be placing this limbal tissue at the nasal limbus on the amniotic membrane graft, and then we'll be securing it with a banded contact lens. And hence the term mislet. Now, this is the surgery. Video is not playing. अलग से एक और वीडियो है इसी में. अच्छा ठीक है. So this is the surgical video. This patient, he has a symblepharon along with the pterygium. We start with the dissection. Go ahead with the extended removal of the pterygium. Here we can see we have to remove the tenons, as we have already emphasized that diseased tenons has to be removed as it's the main reason for recurrence. We have put securing sutures here. So we have to release the symblepharon and we are removing the pterygium. So there are two things, so it might look a little messy here, but we have marked the medial rectus. We have hooked it for you. And we have put the fornix forming sutures here. The fornix is clearly visible now. The tenons has been removed. Just placing the suture to expose the fornix. We need the fornix to be visible because we need to place that amniotic membrane graft. And this is the medial rectus we had engaged earlier on with the muscle hook. And as sir said, keep the scleral area dry, putting in the amniotic membrane graft with securing it with the fibrin glue. And now this is the 1 clock hour of the limbal tissue that we have excised, and we will be putting it over the amniotic membrane graft, over the limbal area of the nasal side. And this has been placed over the nasal side. Nothing has to be done. It is gently placed over, and now we'll be putting a BCL, if you can see. And it's done. Now this is the post-op. We followed the patient, and you can see 1 month post follow-up. There is no recurrence. The patient is doing pretty well. This is 6 months. The patient still has no recurrence. The patient is doing well. So this technique, we can say that for us, we did not find any recurrence in a couple of other patients also that we have done. There is no symblepharon. It gives a very good cosmetic result. There is no ocular restriction, and we didn't have any granuloma formations. And so this is how our patient looked, from the symblepharon and pterygia to the clear cornea and the pterygium-free eye. This is our patient. Slight exophoria. These are a couple of other patients also. I'm just sharing some images. So we had a granuloma formation in one of our patients, a 1 month post-op. Here in the second patient, we have a corneal opacity. These patients are doing well. Now, our thought process, why we wanted to go for this modification in the already perfect technique, was to preserve that conjunctiva, that superotemporal superior conjunctiva, if we require it for some other procedure, like in some patients who probably have glaucoma and we would like to do some other surgery there. So complete and extensive removal of the pathology, we are able to preserve the conjunctiva, and we also got the anti-inflammatory benefits of the amniotic membrane here, and we also achieved replacement of the pathologic stem cells with the normal cells. You can say that in some patients you might find granuloma formations or a slight exophoria. There is no recurrence, there is no symblepharon formation, there is good cosmesis, no ocular restrictions, and we are able to preserve the conjunctiva, as I've already said. So it's a promising technique. We can try it. We can say that probably a lot other people, you can try this technique. It's very rewarding. It's easy. We have not done it in. Our cohort size is still small. We cannot still say how it will do in future. But the number of cases that we've done, and we've followed them for over 6 months now, they are doing pretty well. Thank you so much for your patient hearing.
Thank you, Dr. Amrita. It was a wonderful technique. So any questions about talks till now? Okay, that's it. So because unfortunately Dr. Sanjay Mishra sir is stuck up somewhere, so he won't be able to present. So we would conclude our instruction course. Thank you so much for patient listening. Thank you so much.